Hello everyone, welcome to the Gender and Digital Health webinar series. The topic for today's session, which is the 9th session in the series, is Design Process Evaluation for Digital Health Programs with a Gender Lens, drawing from case studies from India. And we have a fantastic lineup of speakers. Next slide, please. So we have our webinar organization showing the slides, and my name is Ronald Mshishingoza, and I am a postdoctoral fellow at the United Nations University International Institute for Global Health, and I will be moderating today's session. So the Gender and Digital Health webinar series is a platform to foster new partnership and co-create knowledge on the gender dimensions of digital technologies for health, with a focus on translating of evidence to policy and practice-based learning in low and middle-income countries. The series are organized by a consortium between United Nations University, the National Institute for Global Health, the University of Cape Town, and BBC Media Action. So the recordings of the previous section can be accessed on the Gender and Health Hub in our website or in our YouTube channel. So feel free to tweet your thoughts, comments, and reflections, and please may you use the following hashtag GHH Talks or Gender and Digital Health. And also don't forget to introduce yourself in the chat and also ask questions. Next slide, please. So we have conducted webinar sessions since January of this year on different topics since the beginning of the year, and we have 2 forthcoming workshops, one which is planned in the first week of December as part of the Global Digital Health Forum, and also another one which is planned next year in January on methodological innovation in evaluating digital health intervention with a gender lens. So when you register for one of these webinars for the first time, you will receive invitations for the subsequent events. So we welcome you to register and also participate in our workshops. Next slide. So in today's session, I will first of all give a brief overview of the webinar series, and then we'll have an introduction to what is process evaluation, and then we'll hear from 3 case studies with 4 speakers on the presentations, and then we have our discussing wrap up the session, and then we'll finish with a question and answer session. Next slide. So for the previous webinars that we have had, participants have had the chance to register, and then they have attended our webinar through Zoom. And also at the same time, our webinars are live streamed on YouTube, and also participants can view the recordings later on our YouTube channel. So the graph shows the number of people who have attended our participants, and the one which is in blue, it shows participants who have attended via the Zoom platform, and then the orange one, it shows participants who have attended via YouTube. Next slide. So for participants via Zoom, we have managed to have a database of more than 1,100 people, which shows a significant proportion of them being women and also from the low and mid-income countries. And also here, the data for the Zoom characteristics can show that more than 2/3 of the webinar participants were female, and nearly 40% of them were coming from the low and mid-income countries. And also in terms of WHO regions, WHO AMRO and WHO Southeast Asia, they had about 1/4 of participants each, and also we have a sizable proportion, about 20% of the participants which were coming from the WHO Afro region. So this shows that we have been having great progress in engaging with a number of people from different diverse backgrounds, and we hope to continue to do the same in the following events. Next slide. Now, to introduce us to some of the concepts of the discussion today, we have Deborah Jackson, who is also going to be our discussant. Deborah Jackson is the inaugural Takeda Chair in Global Child Health and Deputy Director of the Match Center at the London School of Hygiene and Tropical Medicine. She is also an extraordinary professor at the University of the Western Cape School of Public Health. Prior to joining the London School, Dr. Jackson was the Senior Health Advisor and Chief of the Implementation Research and Delivery Science Unit Health Section at UNICEF. In that capacity, she focused on maternal, newborn, child, and adolescent health program research, data, and digital health. We are so thrilled to have you here today to kick off our discussions on the importance of process evaluation for digital health solutions. Without further ado, I would ask Deborah to please start off today's webinar with an introduction to the key terminology and concept around process evaluation. From there, then we will dive into our 3 case studies before turning back to Dr. Jackson, who will give us reflection. So, Deborah, the floor is yours.
Okay, great. Next slide, please. Okay, so we're going to start, we're talking about process evaluation here, and what it's really all about is implementation. I really love this graphic. It's from a guide from the Alliance for Health Care Policy Systems and Research program, written by Peters. It's available online. That talks about, when we talk about programming, and we talk about innovation, basically we start at the beginning with the proof of concept, and this could be for a drug or a technology, or a, even a program design. So, is it safe and does it work? And that's where you start way over on the left. And here, when we think about the research questions, there are basic sciences, basic technology, generally maybe some early qualitative work. And then as we move along the continuum, we start to move, through what we might call phase, 2 to phase 3 trials, if we're talking about drugs. But the research question is, more about, more of it, can it work? And then as you move to real world settings, it sort of gets to how it works in the real world in the middle there, and then moving on to information for scale up and integration and sustainability. And when we talk about implementation research or process evaluation, we're mostly talking about sort of on the right side of this diagram, the 2 boxes that I have highlighted there, where we could be doing effectiveness implementation trials, we could do participatory research, or we could do a lot of mixed methods. This work is often mixed methods, and you're going to see that in our presenters today. And so what we want to move is from the sort of theoretical world, the idea, and move it through to sort of a real world full scale application. And we're going to see that also across the projects today. So this is a very useful to say, where am I locating my research along this continuum for program innovation? Next slide, please. So here we're really talking today, they're called it process evaluation, but I think I also want you to recognize that it's also part of implementation research. And so what is implementation research? Also from Peters et al., the scientific inquiry concerning implementation, the act of caring and intention to effect in which the health research can be policies, programs, or individual practices. Implementation research is about using systematic research methods to improve policies, program delivery, translation, and preferably through real-time application of knowledge gained in real-world programmatic change. So here, once again, real world, real time. Process evaluation, which is similar, and in the case of Limbane, considers it actually an important component of effective implementation research. And that surprisingly, there's been very little work to understand that constitutes best practice in process evaluation. So they're often, researchers will use different methodologies describing causal pathways, barriers, facilitators, and that's sort of the big word, barriers and facilitators. And you're going to see that as our presenters talk about today, barriers and facilitators. And really what we're also looking at is diverse context and settings, so that we know that we might take a project, a program that's, say, recommended by WHO, but we have to implement it in our community. And in that way, it's got to be, it's going to be very diverse, and we have to make local adaptation. And if we're going to scale it within a country, in particular, we're talking about India today, we all know that that's like many countries. And even within those states, there's many different types of regions. So you have to think about context and local implement adaptation. And finally, the process evaluation is an attempt to document how an intervention is implemented and what was actually delivered. And so we're talking here about terms like fidelity, reach, dose delivered, And then any unanticipated additional activities or data adaptations that we have to make sure it works. And our presenters are going to also speak about that today. Next slide, please. So here we talk about process evaluation, we talk about implementation, and then you can also hear outcome and effectiveness. So you may remember the old, it's actually almost as old as me, is on where we have input, output, outcome, impact, okay? The Donabedian framework. And so basically the process evaluation, once again, in this graphic, it focuses on the left, and then and we're basically the inputs, the activities, and the outputs. So that's the process or the implementation. And it doesn't necessarily work on outcomes. Occasionally it can include outcomes or effectiveness because it's focusing on how we're doing something, not what it's doing. And so we tend to do it as we're also as I said, implementation effectiveness trial, you might combine them, both the process implementation and the outcome effectiveness, or you might use the process and implementation really to we know that something is effective, vaccination, for example, but we might not know, what's the best way to deliver it in, say, a very remote community, or community that has various cultural barriers that we might want to know. And so that we don't need to assess the outcome or effectiveness, but we need to understand how to get it to that community. Next slide. This one we've just recently published in Implementation Science Communications. And really this shows you, I think, the continuum of programming and evidence generation to improve implementation. So we often start with our baseline study, situational analysis, formative research, implementation of our data systems. We start our implementation, then we're monitoring it. And so data collection, review of the progress, process, and then during it, if we see a problem identified with our monitoring, and you're going to see some of that where colleagues have identified some problems and they want to understand why they're having those problems and what they might be able to do about that. They're going to speak about that today. If you understand the problem, you understand the solution, it's just part of your management, your quality improvement, to make it better. But what if you don't understand why what's happening or why it's happening? And that's where implementation research into barriers and solutions can be useful, or process evaluation. And once again, once you get your answer, then you go back to your management or quality improvement, and then you make your program changes along the way. There's a quote, different colleagues use different analogies, but Prof. Stefan Peterson, who used to be at UNICEF, used to say, you're fixing the plane as you're flying it, instead of waiting for the end line evaluation crash, where you see that it didn't work and you don't know why. So that's the evaluation, is sort of your end line or impact. We talked about it in the previous slide. So it's really understanding that all of this is all about implementation, and that depending on where you are in this cycle, you're doing implementation science, you're doing evaluation, you're doing monitoring, and process evaluation is sort of part of that implementation science, part of that implementation research. I don't get caught up in what people call it, because my goal is to help managers run their programs better. And though I'm an academic, and I have many academics who feel taxonomy is important, my district manager running a digital health program does not care what you call it. They just want answers. So make sure that what you're thinking about is how do I help this manager to make a better program? And and then these are the tools that can help you. That's it for me. Back to Ronald. Thank you.
Okay, thank you very much, Deborah, for such an intriguing introduction, which has really set the stage for tonight's discussion. So to move on with our discussion, we now want to deep dive into our case studies, and I would now like to introduce our first panelists, Amnesty Lefebvre and Kerry Scott. Amnesty Lefebvre is an associate professor at the University of Cape Town School of Public Health. She has nearly 2 decades of experience evaluating programs, including digital health solutions for maternal, newborn, and child health. Amnesty, we're presenting today with Dr. Kerry Scott, who many of you may have recognized from some of our prior webinars. Dr. Scott is a social scientist, independent researcher, and associate faculty in the health system programs at Johns Hopkins Bloomberg School of Public Health. Her research examines community health worker programs, village health committees, health enabling environments, digital health, and methodological innovation to improve survey research. Amnesty and Kerry will be telling us today about the process evaluation of the direct to beneficiary mobile health program, Kokari in India. Over to you, Amnesty and Kerry.
Thanks, Ronald, and thank you all for being here today. I know we sort of are approaching the end of the year and we have webinar fatigue, so we are grateful that you're joining us either live or listening after the fact. So Kerry and I are going to give you an overview of our experience designing a mixed methods process evaluation for Kokari, and this was part of a larger Gates-funded impact evaluation that wrapped up in 2020. So for those of you that haven't heard of Kokari, it's the world's largest direct-to-beneficiary interactive voice response messaging service for new and expecting mothers and their families. It aims to generate demand for public health services and strengthen families' reproductive, maternal, neonatal, and child health behaviors. It's comprised of 90 minutes of content, which are delivered through 72 pre-recorded audio messages that span up until the child's first birthday. It was developed by BBC Media Action and adopted by the Ministry of Health and Family Welfare. And since its inception, it's scaled to reach over 10 million women and their families across 13 states in India. Next slide, please. So in this next slide, we've really sought to focus not so much on findings, but more on methods, so that those of you that are thinking about doing your own process evaluation kind of sort of can see under the hood, so to speak, of what went into our thinking on why we did what we did. So we've sought to kind of summarize our thinking about the design into kind of 5 summary steps. So we started by defining the aims and objectives. And again, this is in addition to the broader theory of change, which you can see in the protocol paper Carrie's just pasted the link to in the chat. But in our case, really for the sake of the process evaluation, we sought to define these around population level coverage, reach, and exposure. And we additionally assessed impact as part of the larger impact evaluation. But again, today we're just going to focus our conversation on those first kind of 3 gray circles. Once the aims and objectives were defined, we sought to map out the flow of beneficiary entry to and movement through the program. And this helped us to understand key program activities and refine aims and objectives. We then identified the data requirements, including what data was available to us from the program, such as system-generated data, and what additional data needed to be collected to complement this. And as part of this, we worked extensively with BBC Media Action and partners to achieve consensus, not only on priority analyses, but on key terminology. And I think both of these are really critical design considerations, which often get overlooked in thinking and planning process evaluations. So in terms of analyses, as an example, BBC Media Action had done a lot of work already on system-generated data as part of monitoring activities. And so it was important for us to avoid duplication and overlap and make sure that we were complementing existing efforts. In terms of key terminology, we spent countless months iterating on concepts related to reach and exposure. So for example, does a woman need to listen to a certain threshold of the message in order to be exposed to the content? Or is any listening sufficient? So these kinds of conversations were really integral to our work and our understanding of the program. And in our next few slides, we're going to walk you through the assessment methods and some of the key summary findings related to coverage, reach, and exposure. Next slide, please. Just next slide. Advance, sorry. So as part of efforts to assess population level coverage of the program, we started by defining target beneficiaries. So in our case, that was pregnant and postpartum women with access to phones. And the source data for this, and it's really critical to sort of understand the source data for your sampling frame, these were drawn from government tracking registries and thus women attending public sector services in India. So from the snapshot of the gray flow chart in the center circle, you can see that in 2018, we estimated that there were over 22 million pregnant women in the 13 states where implementation was underway. And of these, just under 14 million were recorded in the government tracking registries. And of these, just under 5 million passed the program's validation checks. And this included a number of fields from making sure there were correct data around the last menstrual period to correct phone numbers. And ultimately, if they passed these validation checks, it was then sort of ingested into the program engine. And then they started to receive calls. And so you can see just from this snapshot of this flow, we sought to really look at the percentage of data loss at key points, which underpins our estimates of coverage. So you can see from these summary findings that a lot of the reason for dropout was incomplete and inaccurate government registry data. So again, poor quality registry data is not the fault of the program. It's something totally independent, but it does impact the program's coverage and the timing of when beneficiaries enter the program, and thus in turn exposure. So to that last point, we found that about 37% of subscriptions occurred postpartum, meaning that women miss out on getting critical Kokari messages during pregnancy. So once we understood that government registry data were going to be a big impediment to high coverage and optimal exposure, we decided to conduct qualitative research to understand more. So Carrie, can I ask you to come in here? Next slide, please.
Yeah, thanks, Amnesty. Hi, everyone. So to understand some of the drivers of incomplete and late data, we conducted a qualitative study in 2 states. This study involved mapping the flow of data at the front lines of the government health system. We realized that the data flow began with the beneficiary herself in terms of her own access to and knowledge of key pieces of information that are required to create a digital record, including a phone number, government-issued ID, and a personal bank account. We traced the data from when or if a pregnant woman decided to seek antenatal care and when the frontline provider started a paper file for her. We examined informal task shifting and the various registers and ledgers where women's data was copied over and over by people with varying levels of literacy and numeracy. Ultimately, the paper records had to be brought to a centralized location and digitized by a data entry officer who had themselves various degrees of support, time pressures, and technological constraints. Detailed findings from this work should be published in the next few months. Back to you, Amnesty.
Next slide, please. Thanks, Carrie. So moving on from population coverage, we move to our next circle, which is around program reach. For this, we similarly went through a process of reaching consensus on terminology. And so, for example, we ultimately defined reach in terms of successful calls, meaning a Kokari call that reaches an intended handset and then is picked up for at least 1 second or more. And you'll see from the bullets in the gray circle that integral to this concept of understanding reach is to look at call delivery, including when calls are picked up and whether the characteristics of subscribers influences how users engage with those calls. So for this, we were able to use RCT data on the characteristics of users subscribed and then look at data on call delivery and pickup in different ways. And I'm just going to show 2 ways in which we looked at that data. We did many more ways, but let's just start with this first figure. Claudia, can you advance for me? So on this figure, I'm going to flash on the screen. You'll see that there's an x-axis where we look at calls over time. So again, there were up to 72 calls, and you'll see from the black, that's the expected calls. Then you've got calls delivered in light blue and calls picked up in orange. And this happens over time during pregnancy and postpartum for those enrolled into the RCT. And what you can see from the changes in the mountain ranges are places where, for example, you have not delivered calls, and this could be for a variety of reasons due to network issues and other factors. Advance the slide for me. So in this next heat map, again, I just want to show you a way of thinking about how to present data. So don't focus so much on the findings, but focus on the idea of ways of looking at how data are presented. And here you can look at call pickup rates across socioeconomic strata. So that's our y-axis, and by time of day, which is our x-axis. So the darker the blue in the box, the greater the call answer rates. And what you see from this figure is that call answer rates are lowest in the morning and amongst the poorest. Next slide, please. So moving away from ways of presenting data, I'd like to now move to our final circle of exposure. Next slide. Great. So we looked at exposure both in terms of listening to individual calls and of listening to calls received over the life of the program. So we're back to our sort of mountain range. And again, we're following a similar approach here to do this of iterating on definitions and then using system generated data on call data records to sort of assess this. And to show you one way of thinking about it, again, I've returned to our mountain range of calls picked up over time. Only this time I've added a horizontal line to denote the percentage of subscribers who listened at a 50% threshold, so that's in the black, and at a 75% threshold to individual calls over time. And what you see is that call listening rates were quite stable over time, and that if a subscriber picked up a call, they tended to listen to the majority of it. So again, the key point here is really thinking about ways of presenting and utilizing data that's already available to you to understand what's happening with the program. So one critical limitation of the data that we have is on call delivery and pickup rates is that we don't know who's on the other end of the call. Is it really the woman, the intended beneficiary? And so to help us explore this, again, we'll turn back to Carrie and the qualitative data to kind of understand what's going on with these listening patterns. Carrie, over to you. And next slide, Claudia.
Thanks. Yeah, so who's actually listening to these messages and why are some calls not being picked up? We had the opportunity to use some pretty exciting qualitative methods to answer these questions. We conducted qualitative in-depth interviews with Kokari listeners, and we identified who to speak with using system-generated back-end data. Click, please. So back-end data is able to tell us for each mobile number subscribed to Kokari exactly which messages they listened to and for how much time. This visual shows our 29 qualitative respondents as the rows and their listening habits as the columns. We're thus able to go to respondents and ask them about periods where, for example, like many weeks of calls were missed and like what was going on there, or where messages were cut, meaning they hung up right after picking it up. Or in the first few seconds. We could even try to explore their thoughts on recent messages that we knew from the backend data had been picked up and listened to by somebody in their household. Next slide, please. We sought an inclusive household sample to understand the whole picture of listening patterns and social norms related to the content of the messages. Click, please. We conducted one-to-one interviews with mothers of the one-year-old children, coming out of that program, and then also sought out their husbands, as well as other family members for additional one-to-one or family group interviews. It was through these interviews with husbands and other family members that we began to get the full story of who was actually picking up and listening to Kokari and how the messages entered a complex social world of existing constraints, ongoing practices, beliefs, and behaviors. During these one-to-one or family group interviews, we were also able to play specific Kokari messages selected to probe on topics of relevance for that family. And we then asked them about what they'd heard. Click, please. Our analysis brought in the more typical thematic analysis approaches grounded in behavioral theory, but also, and I'll highlight here, a dyadic analysis where we looked at data for husband-wife pairs. Click, please. This dyadic analysis enabled us to apply a gendered lens to phone access and use. We compared husbands and wives in terms of what their phone could do, what they know how to do with the phone, and what they regularly do with the phone. The patterns in phone capabilities, digital skills, and frequent use emerged clearly. Here we see one example of a husband with a smartphone, high digital skills, versus his wife, whose phone only has a few features and who herself has limited digital skills. Next slide, please. You can just click ahead, yeah. So we won't get into the findings here, but I'll just paste in the chat where you can find more about this. Back to you, Misty.
Thanks, Carrie. So we wanted to close out with just some summary methodological learnings. And the first is that it's important to think about all potential beneficiaries of a program. So in our case, we were really initially only focused on women, but then we realized phone sharing practices and cultural norms also made it imperative to talk to men and other family members. The second point, and you've probably seen this throughout our talk today, is that system-generated data in the context of digital health programs can really be critical to sort of understanding program implementation. The third point is that you need to plan for contingencies. So as we noted, program exposure was impeded by a range of factors, and we didn't have a lot of time to get into this today, but this for us ranged from the bankruptcy of a telecom operator, which led to that sort of spike in non-delivered calls over time that we pointed to. We also saw high rates of SIM change of about 46% amongst our population, and about economic migration, which led to kind of movements in our beneficiaries across geographic areas, and thus potentially impeded exposure. So all of these factors were not things that we anticipated from the program's outset, and thus potentially impeded our sampling. Next, and not surprisingly, time and money really matter. So we were very privileged to be a quite well-resourced evaluation with a lot of support, not only from the Gates Foundation, but also from BBC Media Action. We also saw specifically within our work that large quantitative data required data scientists, computing infrastructure, and again, program support. So to complement quantitative activities with qualitative research was something we tried to do throughout the life of the evaluation. And because of that, we really saw that our research questions were able to evolve over time and in response to emerging findings. And our closing learning was really that relationships with both sort of partners and donors are key to success. So we wouldn't have been able to conduct a lot of the analyses that we were able to, or understand trends in data that we're seeing without it really being a collaborative endeavor with the implementing agency, in this case, BBC Media Action and the Gates Foundation. So on that note, thank you for allowing us to present, and sorry this was a little rushed, but back to you, Ronald.
Okay, thank you very much, Amnesty and Kerry, for that insightful presentation. And what was most striking about your presentation is how it shows the importance of trying to harmonize both quantitative and qualitative methodologies to understand what's working and what might be improved in the implementation of direct to beneficiary programs. I think this is a great example of an evaluation which was not only well-resourced, as you have said, but also time to follow women's movement through the program. I think what we're going to see from our next speaker, Dr. Lail Iran, is an example of an evaluation with less resources, not being done atop a randomized control trial. I think it's important that we reflect on how design decisions may alter based on when the evaluation is timed to occur with a program implementation lifecycle. Now with that, I'd like to introduce Dr. Iran. Dr. Iran is an independent researcher with a background in public health and medicine. She has over 18 years of experience in leading impact evaluations and guiding programs related to gender equality, family planning, or reproductive health and health systems across sub-Saharan Africa, South Asia, and Latin America. Most recently, she led evaluations for the Population Council, looking at the impact of integrating programs related to health, nutrition, and sanitation among self-help groups in Bihar and Uttar Pradesh. Laili, thanks for being here today to share with us your experiences, and the floor is yours.
Thank you, Ronald, and thank you everyone for joining. I can see from the participant list that there are colleagues who worked with us on this evaluation from the implementing side, as well as the evaluation team when I was working at Population Council. So thank you so much, everyone, for joining. We can move to the next slide. So I just want to give you a quick context on mobile money, and it's very interesting to hear Amnesty and Kerry. There are a lot of synergies and some of the key learnings. This program really was a mobile phone pilot intervention that was layered onto an existing health and nutrition program being implemented within self-help groups in the state of Bihar. And it was being pilot tested in 6 blocks of Nalanda in Bihar. And the self-help groups really are microfinance-based initiatives that have 10 to 12 women coming together that save small amounts of money and use that for loan purposes, either directly internally or also through banks. And in Bihar, most of the groups are supported by the government, by the state entity called Jivika. And so our evaluation was really looking at the layering of this mobile phone intervention on the existing self-help groups that were already getting an in-person training and knowledge on health and nutrition programs. Now, each of the groups is also led by a woman who lives in the village, and she's supported by Jivika. She's called a community mobilizer. So Mobile Vani as a program was developed by an organization called Onion Dev that has primarily been established by engineers from the Indian Institute of Technology in Delhi. And this program was quite effective in reaching several groups of people across other states in such as farmers and other small entrepreneurs in Jharkhand and Madhya Pradesh and other states of India. So when they brought it to Bihar, they were looking to use the same platform to share health and nutrition messages with women. The target audience was mothers mothers with a child under the age of 2. And the program intended to reiterate messages that the self-help groups were already receiving on 4 themes: nutrition, family planning, management of diarrhea, and access to existing government schemes and services related to health and nutrition. So the way the program implemented, which is the input, Deborah did a great introduction of the input, output, and outcomes. The community mobilizers were trained by field officers who were the program staff on what Mobile Vani was, how to call the number, etc. The community mobilizers then went to their meetings, and in the meetings they told the self-help group women about this program, and then the intention was that the self-help group members would call the number as well as talk about it within the household and encourage others to listen to it. So the way the mobile phone intervention works is that the user calls a number, it's equivalent to a 1-800 number, and a missed call is generated. And so usually within 30 seconds, but sometimes up to 2 minutes, the system calls back the number that called, and it releases a set of, begins to play a set of pre-generated messages. And the listener just has to listen to it. Now, incoming calls are generally free, so it really is almost free of cost to the user to listen to it. So this was really the program, and sometimes the user can navigate the messages, and sometimes the user has to stick to the messages. Next slide, please. So while there was an already robust outcome evaluation that was being planned, and it was being layered onto the existing outcome evaluation of the in-person health and nutrition program, we decided to do a process evaluation to really understand how this program was being implemented with this audience and what could be done to learn about potential ways in which this program could be replicated or scaled in other environments. So initially, we had designed just interviews and meeting observations, interviews with the community mobilizers and the self-help group members to learn about how they were able to carry this program forward. But slowly we realized that the scope was going to grow quite extensively. And so we had to do a couple of changes. We had to include analysis of Ivr data that Onion Dev was very gracious to hand us the data, and I'll talk a little bit more about that. We also had to break the whole process evaluation process into a formative phase and a main phase. Another element of the program really also was that, or the mobile phone technology, was that women could actually record their own messages. So in the meetings where the community mobilizers were sharing information on self-help groups, on Mobile Vani, they would also record messages. And that message would go to Onion Dev, would get analyzed and sifted and edited, and then that message would be retransmitted in the days and weeks to come. So a few of the assumptions that the program staff had while designing the program were really had to be changed and had to be modified in light of new realities. So I'll go through some of the assumptions because they'll help us understand some of the data I'm going to present and what were the challenges in the process evaluation. One of the assumptions was that the program staff assumed that all women would have access to some phone and would be able to dial whenever they wished to or needed to. We assumed that women would have basic knowledge of how to dial a phone number and to make a call and receive calls. We assumed that community mobilizers would be able to lead the sessions and trainings on Mobile Money within their groups because these were their groups and they were used to holding and leading weekly meetings. The assumption of the program also was that the self-help group members were the right audience for this message because they were already receiving another intervention that had similar messages, and that they would be interested in engaging with Mobile Money and sharing their information. And so now I can share some results with you in the next slide, please. So one of the findings, and it's a mix of outcome evaluation results as well as the process evaluation, was that we realized that only half of the women had full exposure to mobile phones. And what that means is they knew how, they had access to a phone, either their own phone, and this is a basic brick phone. You didn't even need any higher technology. And they were knowledgeable, they were phone literate. So you can see the very last bar in the column, in the boxes to the left, where the ability to dial a number was only prevalent among less than 70% of the women at baseline. And so that really became an awakening for the program, and they had to integrate an entire component of mobile phone literacy into their program. And that was during the time when we were doing our formative phase of evaluation. So while the first sessions on Mobile Money were held in the meetings and self-help group meetings, a lot of that initial conversation was really, this is how you dial a number, this is how you wait for the missed call, this is how you pick up a phone. And so that literacy really was a component that wasn't originally designed into the intervention. And to the right, I want to just share some quotations that bring to light some of the gender dimensions around accessing this program. So one woman says, I cannot listen to Mobile Money much because my husband takes the mobile and keeps it here and there. Another community mobilizer actually talked about the very same point about the literacy, and she said mobile phone literacy. She says many changes have come now after the arrival of Mobile Money. Now all of us know how to dial mobile phones and are making calls by ourselves. So this really brings to light the two dimensions of the program. Next slide, please. So another component that I want to bring up here was that a lot of capacity had to be built also for the community mobilizers to share Mobile Money in the meetings. So not only did the community mobilizers have to learn how to learn about the program, but they also had to be guided on how to train and assist the women in the groups. And the field officers not only conducted trainings at central locations, but then they then went to every single community mobilizers meeting initially to help them, guide them on the trainings in the meetings. And this slide really shows that a lot of the reasons for why the women were, excited to listen to Mobile Money was that they had the convenience of listening to it anytime they wanted. And they were also excited about the user-generated data, or the data that was being recorded by the women. So even though the original themes were around health and nutrition, soon after the implementation of the program, Mobile Money had to integrate an expanded scope on the topics that they were covering. So now it was not just the original themes, but there were local news was being integrated, stories of entrepreneurship that women were sharing as a result of joining Jivika were a great source of motivation. And that was what a lot of the women also in other groups who were listening to pre-recorded messages were, motivated to listen to. And there were also some local folk songs, etc. So, so you can see the quotations on the bottom of the screen where the women say, I feel motivated by listening to the stories of other successful sisters. And other women have also said that they started a business after listening to stories of women who had started businesses in neighboring villages and neighboring blocks, and they followed suit. There were a slew of reasons for why women couldn't listen to Mobile Money besides the one I've already talked about in the previous slide. And one was a lack of time and apparent benefit. So if they didn't have a young child at home, or they didn't have anyone in the family, then they didn't see the utility of this. And one of the ladies says, I spend an hour in weekly meetings. I don't feel there is any benefit of listening to Mobile Vani. If I spend the same time to sew clothes, I can make some money. So we had these contrasting statements, from the women in the communities of what some of the reasons were for why they were not listening to Mobile Vani. So next slide, please. So when it came to sharing information on Mobile Vani to others, because this was a key element of the theory of change within the program design, we noted that over a third of the women who had heard Mobile Vani said that they had shared that information with others in their family, including husbands, mother-in-laws, and sister-in-laws. When I was in the field with my colleagues at Population Council, we even interviewed an older lady who didn't even have anyone in the family for whom the information was relevant, but she gave 2 examples of neighbors who she had come to the rescue for and actually assisted them in seeking emergency health care because she knew the signs of diarrhea and what were the signs of pneumonia. And she had learned a lot of it from the conversations that came, that she had heard on Mobile Vani. Though I do want to add here that getting information actually for process evaluation from the field was initially quite challenging. Even though a lot of effort was being made to share this information, to share information about Mobile Vani in the self-help groups, it was sometimes very hard to find women who had heard enough about Mobile Vani or on Mobile Vani to even be part of the process evaluation and the in-depth interviews. I remember an investigator calling us one day and saying she had spoken to 17 women in a village, all self-help group members, and she hadn't found anyone who could tell her more than just the very basics she knew about Mobile Vani. So someone who hadn't really engaged with the program quite extensively. So moving on to the next slide. So in summary, we really learned that the program was as much about using the mobile phone technology than it was about implementing a program on the ground. And while the program had been successful in other contexts, running this program within marginalized populations amongst women in rural Bihar was really going to involve a different set of challenges that we would have to address. So I haven't really shared any results from the Ivr analysis here. I feel like that would be an entire presentation on its own. But we did learn a lot along the way and had a lot of, it took about a year for that data to get cleaned up and prepared for us to access it, and then to work with Onion Dev after that to really analyze the data and glean some findings from it. And along the way, the program did undergo quite a bit of changes and made it very challenging for the process evaluation to adapt to this changing environment. But they had to do it in order to ensure there was interest in the program, there was coverage, there was enthusiasm, and there was going to be, adequate exposure, which did turn out to be quite challenging as well. But in summary, I'd just like to end by saying context does matter. And when the program does go to scale, a lot of the elements we've highlighted would have to be taken into account. So thank you so much.
Okay, thank you very much, Dr. Iran, for such an exciting presentation and also highlighting the synergies from your case studies from the previous case study of Amnesty and Kerry. And also what was also striking from your presentation is this real focus on pathways, impacts, and drivers of implementation to scale. So to move on with the discussion, we would now want to hear from Promina Menon. Promina Menon is a senior research fellow at the International Food Policy Research Institute and is based in New Delhi, India. She conducts implementation research on scaling up maternal and child nutrition interventions, including evaluating large-scale behavior change communications, programs in nutrition and health. She additionally co-convenes a global nutrition policy course with the Institute for Development Studies in the UK and serves on several national and global advisory groups, including the Global Nutrition Report, the Countdown to 2030, and others. In Dr. Menos' talks today, she is going to tell us about her work as part of the Poshan initiative in India, which aims to support more use of evidence for nutrition. Over to you, Dr. Menon, the floor is yours.
Thank you so much, Ronald, and thank you to the organizers for having me here today. It's a real pleasure to talk about one of the research experiences that we've had under the umbrella of the Poshan program. So I want to talk about the research, the process evaluation work that we did in the context of what is the world's largest nutrition program, the Integrated Child Development Services, around 2017-18. So the program has about 1.4 million community health workers who spend many hours of their month updating registers, records, and keeping track of mothers and young children who they need to deliver or coordinate a range of different services for. So the idea of integrating technology, which is, it's not just an app, but I'll describe that in a bit, into this large-scale program was really based on the premise that, removing some of the, the laborious work of maintaining multiple registers and tracking services, et cetera, which has been done manually, removing that and replacing that with technology could help to smoothen and support some of the services that needed to be delivered. And so a technology tool that had been tested in a smaller randomized controlled trial in Bihar was picked up to design a larger at-scale national technology integration application called ICDS-CAS. It's called the Common Application Software. And the interesting thing about the technology intervention itself is that it isn't just an app. So what happened as part of getting frontline workers to use the technology intervention or the app itself, they had to actually be given all of the hardware and the network connectivity. So the entire intervention included smartphones that were provided by the government, SIM cards and network connections provided by the government, the application itself called ICDS-CAS. And then what it delivered was, a setup where the app would consolidate data. So the health worker called the Anganwadi worker would interact with the beneficiary who would, and in that process would bring data into the app. That app would then would sort of integrate that data, consolidate it, bring information back to the health worker herself on following up with the client populations. It would also generate dashboards to enable supervision. So in a sense, it was a very complex technology system, not just an application, and engaged many different actors across the system. My team, and my next slide, please. My own involvement with this came in the context of being part of a multi-disciplinary, multi-institution evaluation team. We were the ICDS-CAS evaluation team led by the University of California, San Francisco, together with University of California, Berkeley, and India-based organizations, Nirman, Accountability Initiative, my own team based in India, and a technology evaluation technology company called ThoughtWorks, which did the technology evaluation. So what we did was this, bundled evaluation. It was a multi-component, highly engaged evaluation of the integration of technology, writ large, the phone, the application, the data connections into this flagship nutrition program. We did an impact evaluation to assess the impacts of the integration of the technology. What I'll speak about today is more the process evaluation. We've also done a cost analysis, and we did a technology evaluation to assess user experience and other such things. Next slide, please. So in the process evaluation itself, we, given the complexity of this program and the number of systems through which it needed to to sort of really move for the hardware to be procured, for the software to be installed, for the network services to be available, for the health workers to be trained, for the other data users to be trained, we decided to ask a series of questions around, upstream and contextual factors and processes that affect the rollout of the intervention, look at the midstream and contextual factors actually affecting the use of the application by frontline workers. And finally, we wanted to look at how client populations themselves felt with the introduction of the technology. We developed program impact pathways. We identified key research questions within these three big bucket areas. And then we really linked data collection methods all the way through to the impact pathways. So we spent, a very long time trying to understand the program and then build the research into it. Next slide, please. This is just an example of one of the impact pathways that we co-developed with the teams, where we try to understand the, all of the upstream activities that led to the rollout of the technology in this particular system. It included things such as device and data management, which is the boxes you see in blue, training of many different people across the ecosystem, which included, which you see in yellow. And then boxes related to actually putting in place the human resources to support this technology integration, which related to hiring and HR placement. And really the key thing in the middle is that the health workers actually use the application, and we end up focusing often a lot of our research efforts on that, those kinds of things that are really at the front line. But when you're studying things that have to unfold in systems, we realized it was very important for us to understand how the entire system was supposed to move, and then to tailor and build our research alongside and around those. Next slide, please. So, one of the things we realized when we did that impact pathway mapping is that sometimes literally from one step to the next step in the impact pathway, when you put a time element on it, it was clear that it would take maybe 3 months or 4 months. For example, just putting in place a government procurement mechanism for smartphones is a pretty big deal, and it can take quite a long time. And so, what we did was really understand not just the pathways of the program, but also understand time and the importance of sort of then temporally sequencing and aligning our own research with the way the program was rolling out, staying engaged, staying responsive, staying flexible, and using many different methods in how we did the research. So we did about 5, maybe more, 7 or 8 rounds of data collection, really different types of data collection. And one of the things we did in those days, which we called an innovation, and of course today in the context of COVID, it's not really an innovation, but we realized that because we were in evaluating a technology intervention where workers had been given phones, that we could actually deploy phone surveys to get quite a bit of data without actually having to send enumerators out to the field. So one of the things that we were doing in this before we did COVID was actually, before COVID hit actually, was using technology to also collect data, which was very interesting. Next slide, please. So what did we find in doing all of this? We did our research in 2 states, and our findings were quite consistent. Firstly, we found that the app itself, because a lot of work had gone into the development of the app, that the frontline workers found it remarkably easy to use the application for most things that related to their day-to-day jobs. And so you see sort of very high levels of reported ease of using the app in these slides. The only thing which was a little bit more opaque and more challenging for health workers was the idea of using the app to generate their monthly progress reports, which they were used to doing more on paper in previous times. So overall, we were able to see that the workers themselves were valuing it and finding that the technology was easy for them to engage with. Next slide. At the same time, throughout our process evaluation and really we did many rounds of this. So this is one of the early rounds where we found a range of different challenges that the health workers were facing in using the app. These were issues related to slow internet, related to network challenges, to time it was taking to submit forms through the system, the interactions between the health workers and their supervisors, and then a set of issues that also just related to their app itself, or the hardware itself. So it was really just a recognition that if you want to unfold and roll out technology, you really have to think about the full range of issues that affects how technology works in the hands of the ultimate user. And we were able to use these findings to come back to the people supporting all of this implementation to get them to chip away at these problems systematically. Next slide. We also were through the technology evaluation, which was really looking at the heuristics and trying to understand the user experience, was really able to identify areas, for example, in specific modules where there were confusions about simple things that looked like colors, where the frontline workers were confused about, the colors that we used in their schedulers. The heuristic and usability findings, really brought up the idea of the number of different icons that we used in the scheduler module, and how just simple things like that could contribute to challenges in the application. And again, these were all conveyed to the developers, and they were able to improve on this. Next slide. Now, in terms of challenges and opportunities for scaling that up, what we found was that nearly all the frontline workers were reporting at least one challenge. I mentioned these challenges before, so I won't go to that. But at a systems level, what we found was that because this was a nationally driven program, the fact that the process evaluation had accounted for those systems level issues in our research meant that we could identify those. We could identify the importance of engagement between the central government and the state, the importance of getting state governments to own something that was really driven from a national agenda, the need to invest in staff capacity and sort of really creating a shared vision. And then, of course, tempering expectations by recognizing that the app itself is situated within the larger context of this big program. So you really have to decide what is it that you can expect from the app when you also have other things that need to be dealt with in the context of the larger program. Next slide. Now, we invested tremendously through all of this. I think this is where this process evaluation also became implementation science, or really sort of built on principles of implementation science. So through the 3 years or 2.5 years of the program of work, we probably held about 30 to 35 formal engagements with the many different users, funders, the government, and others. As part of this, findings were shared with both the national and the state government and with development partners. We found that what we shared in the research spurred the implementation support teams to discuss the findings, sometimes go out to do their own fieldwork to confirm the findings, and to do that in ways that help them identify solutions to the challenges that we were finding in the process evaluation. It really, for us, brought home the idea that you can't just do your research and sit somewhere. You really have to think a lot about and invest the time in repeatedly sharing the findings of your research with multiple audiences in the context of a program that was as large as this. Next slide. So to conclude, I want to say that, what we found in the end was that, of course, this was, it was less than perfect, but given the scale, the scope, and the ambition, it was a tremendous beginning to kick off and roll out this, this big fat program. And doing it the way we did helped us identify that it was a great beginning, but that it also was offering many opportunities for improvement. And through the work that we did in the process evaluation, we were able to help the designers improve the app. We were able to help the implementers support and identify ways to tackle some of the challenges, such as internet connectivity, etc. We were also able to identify that, of course, gaps do exist. I mean, right now, for example, the program has moved on. They've actually removed CAS and are talking about rolling out a new technology platform. But the issues that we had identified, about the need to replace the phones, to plan and to finance for that, to think through issues of data use, data confidentiality, integrating a centrally designed app with the needs of people in a decentralized context, that these are all sort of really remain prominent issues that need attention rolling forward. Needless to say, this is a program that put technology in the hands of, at the time that it was at its peak, nearly more than 500,000 women frontline workers. And one of the things that we really found through our research, but really through what we studied after and in the context of COVID, is that these women frontline workers were really empowered and engaged in multiple ways through the technology. It wasn't just an app. It had put phones and smartphones in their hands. It had put data within their hands. They were using both the app of the government, but also they were using WhatsApp to stay in touch with each other and with their supervisors. They were making phone calls to their supervisors. They were making phone calls sometimes to their client populations. And this is really something that actually played a tremendous role in enabling service delivery and coverage during COVID. We have data on that as well through interviews with about 5,000 of these health workers, but that's a topic for another day. So for now, I'll just stop, and I'm really happy to answer questions and comments as we go through the rest of this webinar. Thank you so much again to everyone for this opportunity to be with you today.
Okay, thank you very much, Dr. Menon, for such an exciting presentation. What intrigued me much about your presentation is how you emphasize about the need to understand how technology affected people, especially in process evaluation of technological problem, and how you as a team, you managed to introduce innovation into some of your projects, which managed to pay off even now when we're in the context of COVID-19. So to move on with the discussion at this point, I would also like to welcome Dr. Jackson so that she can give us our remarks as a discussant. So over to you, Professor Deborah Jackson.
Next slide, please. So, you've heard from these three process evaluations about implementation science, and really the focus of all of their questions is how do we do this? And that we often think of when we're asking implementation research or process evaluation, different types of questions. And you often ask different questions depending on where you are in the program cycle. So, it starts with exploring and then installation of the program. So starting it up, the early phases, then moving to initial implementation, and finally to full implementation. And I think we had some really great examples of three different programs at different stages of this implementation cycle. This graphic is also from some of the work from both TDR and the Alliance for Health Systems Policy and Research around, what are implementation research questions. And so what you see here is the ICDS CAS project that Dr. Menon just spoke about. They looked at appropriateness. So appropriateness is when they were the graph about the response of the health of the AWW. How appropriate was this? Acceptable. How acceptable was this for them to use? And so that was that one graph. That was acceptability. Whereas appropriateness, I think, focused on what was very interesting is when they talked about the app and the colors and the different, and that they had to then redesign the app because it wasn't appropriate, in the way that they could understand it. And that appropriateness also often has to do with cultural aspects, which, of course, always brings us to a gender question. And then also feasibility, she spoke about the network and the phones and the gaps. A lot of those were, what made it less feasible? What did they have to change to make it more feasible for this to work? I think one thing that Dr. Menon spoke about, which I think is probably the most important thing, if you hear anything today, hear this. You cannot do implementation research without implementers. It's not implementation research if you're not including the implementers, the people who are really going to use the data, whether that's program managers, community members, community health workers. You've got to be answering their questions, their local challenges, taking into account their context. That's implementation research. You can't do it without them. And so whenever you're thinking process evaluation, you're thinking implementation science, you're thinking implementation research, you as the researcher must engage with the program managers, the communities, whoever is going to be needing to use this information. Next is, we're looking at Mobile Vani a little bit further along. And they were sort of looking at installation and an initial implementation. So feasibility as well as, adoption and fidelity. And so, as they looked at it, they had a lot of similar questions to Kokari, but they were at a slightly earlier stage in the process, had a lot of similar findings in terms of women not having phones. So, but they were very early on, and they were still taking on things like feasibility, like looking at, okay, we assumed that women would have phones. And then as they looked at it, they realized that women didn't have phones. And so that, what their main assumption that made their project feasible was that women would have phones. And then they found out that half the women don't have phones. So that meant that right off the bat, they've got some feasibility issues, as well as adoption and fidelity. Who was listening, how people were using it, understanding how it was actually getting to people. Which then brings us to Kokari, which has a lot of the same questions. But they were quite farther along. You could see how many, as you said, the largest program in the world, so they're really at almost at full scale, right? 13 different communities. It was like, it's huge. So they were working more at the initial implementation to full implementation phase. So they looked at coverage. A similar question to Mobile Vani, but they were looking at it on a much bigger scale in terms of coverage and who was actually getting the intervention, but also adoption and fidelity. So were the women getting what they actually needed? Which I think is very interesting with regard to adoption. So were they actually picking up the phone, and who was picking up the phone? And then were they getting what they actually were supposed to get from these messages? And so you could see how that along the way, when we think about how, we have to realize first where we are in the process and what kind of questions we would expect to be asking at those various stages. We have to realize, and then we have to think about those questions. I think what was also interesting is Dr. Menon said that they had done a cost analysis and they had done an impact analysis, okay, outcome and impact. And so what I really like about that is that we should be, even for clinical trials, even if you're doing a randomized clinical trial, particularly if you're doing a programmatic intervention, you should have some process or implementation research in that. Because when it's all done, you need to describe what you did. If it works, you need to be able to describe what you did so other people can actually do it. And not just, oh, there was this group and that group and whatever you call them. You need some details. If it doesn't work, you're probably going to need to know why. And so you're going to need those details. What I would prefer to hear, but this is always difficult in clinical trials, is that if it's not working and you're seeing it's not working, fix it before you actually move on. If they're not getting what they're supposed to get, then, are you really running a proper trial? And if you just keep running the trial, knowing that people aren't getting what they're supposed to get, and that it's not really working, aren't you wasting a lot of money? So I think you have to address these issues when you're doing work. And I love to see implementation science included in, from early on, starting to understand that implementation. And then I think sort of finally is, thinking about, impact and effectiveness. And, that here we're looking at process, going back to that input and outputs and activities. Those are the process part. And then we think about outcome and impact. Now, none of these reported on outcome, though some of them are doing it. So what would be the outcome? The outcome here, I think what we're looking for is probably better behaviors in pregnancy, and because these were mostly all pregnancy, we're looking for better behaviors, more knowledge, attending visits. Those are the kinds of things that we're looking for. Those are the outcomes. But impact is always going to be hopefully our long-term health impact. So that's when I just want you to, we've been talking about the early part of the process, but I also want you to recognize the later part of the process, that there's outcomes and impact. Impact is mother doesn't die, baby doesn't die. Impact is the baby's healthy, the mother's healthy, so that those are, obviously you can have other impacts, but those are the big ones. That's what we do this for. But the fact is that we can't just measure mortality. We have to understand how we get there. And that means understanding our programs, whether it's a digital intervention like this, whether it's a program using, community health workers versus nurses in the clinic, whether it's a new drug or a new vaccine, COVID vaccine. Our big problem is not going to be that the vaccine doesn't work, it's that we can't get people to take it. And that's a completely different implementation question. So those are my quick comments. I think these were all amazing studies. You can really learn a lot from them. And I think the fact is that when we talk about gender, all of these, their challenges and their barriers were primarily gendered, because they were trying to reach women and women didn't have the phones. And that was, so that we need to go back and we need to put this kind of gender lens on when we're looking at programs, to say, okay, this is it's a gendered issue, and how are we going to address it? How are we going to make it gender neutral and or gender, promote gender equality? So thank you very much for letting me discuss and learn about these programs. I really enjoyed it. I hope you did as well. And hopefully we'll have time for Q&A. Thanks.
Okay, thank you very much, Deborah, for those thoughtful reflections. And with our remaining time, I would like to pose some questions to our panelists and also to our participants. If you've got questions, continue to put them in the Q&A section and they'll be answered with our panelists. So my first question is, from the discussion, we have seen that across all presentations that women in India have limited access to mobile phones. And Lily, in your presentation, you reflected a lot around the gender dimensions of phone access and use. I wonder if you could comment further on how you think that limited access to and use of phones impacted your evaluation of the mobile VANI program.
So yeah, I think I was able to highlight that it was really, even though there is a lot of there's a lot of mobile phones in the community, and you can see 99% of community mobilizers had a phone, and 70–80% of women have a phone. It's the exposure. So whether they have access to it all the time matters, and whether they know how to use the phone matters. And also there were other gender dimensions which we couldn't bring up. For example, one of the things that was very interesting for me that came out from the interviews is that it was inappropriate for women to be listening to messages on mobile phone for a long time. So they couldn't be holding their phone and talking or just listening to messages for long periods of time. And I mean, that was also very interesting. Yeah, I think overall, just also having access to basic, mobile phone charges. So the very minimum charges was also a critical element that also came up in exposure and being able to use the mobile phone. There are many, many other angles to it, and there's a lot of information my team and I were able to pull up, but these are just two examples I'll highlight.
Okay, thank you very much, Lily, for such a response. And now to move to some of the questions which are in the Q&A section. There's a question which is directed to all panelists from Alison Redu. She said, I often work with organizations that are new to applying a gender lens to digital health or need to be convinced it is relevant. When you were designing your process and impact evaluations, did you use a framework to systematically build in gender? And if so, can you share it? Or do you have any other advice for systematically building in gender or feminist lens to process and impact evaluations. So this question is directed to all panelists, or maybe Dr. Menon, do you want to first respond to this question?
Sure, I can try to do that. So, in our situation, the health workers and their supervisors all female, right? And so we didn't actually explicitly take a gender lens, and of course the client population is also predominantly female. So in a sense, we didn't take an explicit lens to do that. But as I reflect on it, I can certainly see that we were in a situation where if you went further up the systems chain of the program, many of the decision makers were around a lot of things that happened in the program, and that would of course affect the female frontline workers. A lot of those decision makers are male, and we don't sort of fully understand whether, for example, having more women, or in this case, maybe not so much women, but actually having more, voices from the ground, from the frontline workers themselves in those decision-making spaces. We don't sort of fully know, how that would have unfolded. So I guess one thing I would say here is maybe not just to have a gendered lens, but also really think through the implementation hierarchies that exist in some of these large-scale programs, and maybe what we need is more of an equity lens. Are people who are affected by the decisions that are made at a level of management, are they actually involved in any way in those decision-making spaces? And I think we see very few examples of that. In a sense here, the research brings the voices of the frontline. And so I feel like one of the things that we were able to do as researchers, using our places of privilege and our ability to be in those conversations with decision makers, was to bring the voice of the frontline workers into our data and therefore into the rooms, but they weren't present in any other way necessarily. So I would say, having an equity lens, but also thinking about ways in which we bring those voices can be a very powerful way to take this forward. Thank you.
Okay, thank you.
Just Ronald, can I just ask a follow-up? So I'm also I think it's such a critical insight that you just had. And I wonder if you think about then the next version of a frontline health worker app that might come up for Anganwadis, how from the outset do you get, do you reflect those voices from the ground, given that, CAS had largely been developed when you guys joined. And so almost your voices become not an afterthought, but well into the space of implementation. So how do you get that voice in from day one on sort of equal priority, I suppose? Over to you.
I honestly don't know. I'm gonna say, I know that, we had the advantage in a sense of being part of the formal stakeholder community around ICDS CAS, because the research and the evaluation was, a formal part of that entire program. I don't know if it is currently in the new avatar of that, of the technology intervention. But I really believe that, especially people who are doing implementation research and process evaluations, have the ability to bring the consolidated voices of, many of these frontline workers into the room. And so, embedding into unfolding new technologies and new programs, and really not just new technologies, but anything that has to affect the frontline, embedding implementation research in can really help to bring in consolidated voices of many people in the system into the decision-making spaces. Thank you.
No, great.
I also just see if this is coming more back to Allison's question about the gender lens. Claudia, if you can just scroll forward 2 clicks. I don't know if it'll work because just forward, sorry, like advancing, not back. Yeah. Oh, it doesn't work because I changed the Google Deck while you were still in presenter mode. So don't worry about it. I was just going to note that there are a couple frameworks that might be useful, Allison, when you're talking to people about these programs. Oh, there it is, slide 55 and 56. So this one came out of the Kokari work, but it really echoes what Layli was saying about the barriers to phone access. And I think that when we look at what frameworks can be useful in bringing the gender lens, there are certain frameworks that are around sort of the mobile access and use part. And then there are some frameworks around the program content and focus. So this one is really around the mobile access and use. And it just lays out exactly what Layli was noting from her research, these immediate barriers, the ones in the red circle, including that time allocation and the permitted and desired use. So we had a lot of women saying, I can't be seen on my phone a lot, or what would I want to do with the phone? I only call my mom. That's the whole point of the phone. So it doesn't need to be near me throughout the day. And my husband needs it for work, and all these things that Layli has mentioned as well. And then this framework might be of some use, looking at the phone, the gendered aspects of phones.
I think, Carrie, if for those that want to hear a whole lecture on this, Carrie, you talk through the logic of each of this earlier in the year. So go to I think Ronald on early slides had the UNU webpage and the webinar link. So if you're interested in this framework, Carrie does like a whole presentation on it. That's awesome. I'm biased, but I think it's really good. So if you want to see it, it's in the beginning. So you can see it there, but I think it's here in the chat, and we'll paste it in the chat in a second. And then I think you're going to talk about one more framework.
Yeah, Allison, the other one I was just going to mention, I had nothing to do with the development, but I come back to it all the time. It's the very last slide in the whole deck. I just popped it in there, taking a screenshot. But I mean, you've probably seen this one, but I just find this is like always a helpful one to come back to when we actually think about what our programs are doing, what messages they're sending out. And in case I also find it's a really nice one to get people talking. It's quite accessible. So this is just another one to flash about thinking about the integration of gender into our programs, whether we're taking a exploitative approach, benefiting from the existing inequities, or accommodating gender, or actually seeking to transform it. It's kind of
Carrie, will you
something we
put the
can all
link
look
to
at.
this in the chat? I don't know if the source document.
Yeah. It's I'll throw that in there too.
And then just quickly, I know there's a lot of comments happening in the chat. I know we probably have 4 minutes left, so we may not have time to get to all of them. Purnima is frantically trying to answer big health systems questions about frontline health workers and digital tools. No pressure, Purnima. I'm sure you'll come up with all the solutions for everyone. But anyway, back to you, Ronald.
Yeah, that's all for me. Just about Allison's question.
Ronald, you're on mute.
Thanks, Claudia, for juggling.
Okay, thank you. My next question is Amnesty and Carrie. It's to Amnesty and Carrie, because we're evaluating a direct beneficiary program, you're able to look at exposure using the core data records. This is a unique component of the evaluation. Can you comment a little bit on challenges of working with this data, and what did you learn from these experiences?
Carrie, can I start? And then I'll hand it to you. Yeah. So this is the third large direct to beneficiary program where we've looked to analyze call data records. So we did similar evaluations of much smaller scale with less resources in South Africa here, where it was text messages, and then with a similar program in Ghana, which actually had IVR call records as well. And in all of those instances, there were major challenges around getting technology partners to give us the data. Often, the donor would go to them and say, you need to give the evaluator the data, or the ministry, in the case of South Africa, the Ministry of Health said to the technology partner, you have to give them the data. And they would say, yes, yes, yes. And then we wouldn't get the data, and months and months and months would go by and wrangling, and you would try and figure out what's happening because they had committed to giving the data. And then you might get a dump of data that's totally unusable or indecipherable. They couldn't give you code books. They couldn't explain labeling. There were lots of problems with it. So when we started the impact evaluation of Kokari, we actually had the opposite experience in that there had been a lot of work already done with the data to look at, the factors underpinning exposure. It was very clean. It was completely accessible to us, and we didn't have to have any of this wrangling. It was, you have permission to access it. We'll actually work with you on it. So it was quite a refreshing change. And I think when, there was sort of synergy, to Deborah's point, between the program and the evaluation partners, where we all agree this is important. We're not here to catch anyone. We're here to work together towards a common objective. We actually could do so much more with that data. And it was so integral to determining that impact, because we were then able to sort of look not only at sort of program policies and strategies around, for example, program design decision around the number of times you call someone. And is that like a pro-poor thing? Because it has obviously cost implications. In other words, if I call people more, do I actually reach the poorest? And that's what we ended up seeing. But even to do that analysis, requires being able to not only get the data and understand it and interpret it, but in our case, we also were able to link those data with our RCT data to run some of those analyses and then look at, the impact of core design decisions, which have a lot of resource implications. So that was, I think, a sort of a unique aspect of what we could do with this program that had more to do with the strength and the capabilities of our implementing partners and less to do with us. I do think if I were undertaking an evaluation of a direct beneficiary program, I would make sure that our contracts with the donors had it worded that those data had to be provided to you in a timely fashion. And I would specify what that is and in what format and all of that, because you can really get into hot water, because you can get the runaround, and to really get good data scientists is really challenging. And we were really lucky. That was the other thing. Our dear colleague, Dr. Diwakar Mohan, is not on the call today, and neither is Dr. Jean Bashingwa, but the two of them were just awesome. And so we could do the analysis we could do, and some of which I presented today. It's entirely their work. It's not mine. So again, we only could show that because we had a very deep, strong bench of colleagues that were highly skilled, capable, and willing to kind of do it and explore evolving research questions. So that's my short answer to your long answer to your short question. Carrie, did I miss anything?
No, that was great.
Okay,
cool.
Thank you very much, Carrie and Amos. And with that, we have come to the end of our session. And I would like to thank our amazing panelists and our discussant, and also our participants who have been with us today. So you should make sure that you sign up to be part of the Gender and Health Hub at genderandhealthhub.org so that you cannot miss on future events. And also you can follow us on our social media platforms at Twitter and LinkedIn. And with that, I would want to thank you and everyone for being part of this webinar session. And may you please have a pleasant day, pleasant evening. Thank you. Bye-bye, everyone.
Thanks, everyone. In particular, thanks to Deborah. Thanks to all the panelists. We'll see you at the next session, everyone. Thanks.
Thanks,
well
everyone.
done.
Thank you.
Thank you.